help we have started this activity, and you were the first speaker. So today we are going to talk about prostatic biopsy under local anesthesia. And I am happy today again we have a guest speaker, Dr. Ananda Dhanasekaran. Thank you very much, Dr. Ananda. And today we have Dr. Tariq Sami as the guest speaker. Thank you very much. So sorry for a few minutes delay. So without delay, we are going to start.
Sure. I will share my screen and then we can start. I've sent a request for sharing the screen. Somebody needs to accept it. Yeah, thank you. So everybody can see my slide?
Not yet.
Okay, we'll wait.
Yes, now.
Okay, good. So today we will discuss about local anesthesia transperineal prostate biopsy. As we all know, prostate biopsy is one of the very commonest and large volume procedure done by the urology consultants, trainees, junior doctors, nowadays even the auxiliary nurse practitioners or advanced nurse practitioners. We have done prostate biopsy by using transrectal approach for many decades. Those who have done transrectal biopsy, sometime you will come across patients where before the biopsy, if you are doing a digital rectal examination, you may find patients the lower rectum is smeared with feces or sometimes loaded with feces. You will be a bit doubtful that if we take the needle through that lower rectum mucosa where already there is feces, are we doing a harm by taking the microorganisms when the needle is going in to take the biopsy by creating infection in the prostate? That's why prostate cancer diagnostic pathway, especially the biopsy part of it, always have the chance of infection. Even in the transrectal biopsy, the biopsy infections are not that common. For example, the audits done in our own department has shown an incidence of only 0.2%, which means 2 people out of 1,000 patients. But the problem comes in two ways. Once the infection happens, sometimes the infection is so bad to the level of septicemia and to the level of even patient's death. I'm glad to see Mr. Sami has joined now. Hi Tariq, thanks for joining.
No problem. I actually joined earlier, but for some reason
we're not able to locate you.
Through, and then I had to send you
okay.
A text message. So good morning, assalamu alaikum, everybody.
Thank you, Tariq.
Yes. Welcome, Dr. Sami.
Thank you very much for inviting me, and please continue.
Okay, Tariq. We'll discuss it end of the presentation.
Yeah.
So two main things, as I said, the problems with transrectal approaches. The first one is infection. Even though it's rare, when it happens, it's very difficult. We know how difficult the prostatitis can be treated in the normal clinic situation. Prostate, even though is an organ with good amount of blood supply, it's not good enough for the antibiotics to reach quickly. That's why men, especially those who are immunocompromised, can easily get prostatitis or prostatic abscess with prolonged need for antibiotics, hospital admission, etc. There is a small element of even death when the infection due to prostate biopsy has gone out of hand. The other main thing which is against the transrectal approach is use of antibiotics. Every patient who needs transrectal antibiotics should have prophylactic antibiotic. As we know, prophylactic antibiotic is defined as the antibiotic given to a procedure where the infection is expected. Here, We are giving prophylactic antibiotic because there is a breach in the mucosa. The problem with the antibiotic usage is the choice of antibiotics. In transrectal prostate biopsy, the commonest antibiotic used in ciprofloxacin and commonest organism is E. coli. And we know that slowly in various parts of the world, E. coli has become resistant to fluoroquinolones like ciprofloxacin. This forces us to select alternative antibiotics or superior antibiotics, which further only complicate the antibiotic stewardship throughout the world. The other problem is the problem due to the ciprofloxacin itself. There are new evidences coming up the unsafeness of ciprofloxacin, especially if it is given for longer duration, like creating weakness in the tendon, fracture in the tendon, etc. So it's all the more reason important to have an alternative method by which we don't have to travel through the rectal mucosa. So that's why this transperineal prostate biopsy has come into place, where instead of going through the rectal mucosa, we will pass the needle through the perineal skin, where we can decontaminate the skin by using povidone iodine, just like any other skin preparation for like laparotomy or any surgery, and then everything is sterile. Transperineal approach, even though it has got a learning curve, even though it is slightly uncomfortable to the patient because we need to use a perineal prostatic block, which involves local anesthesia, which involves a needle, and it's an uncomfortable prostatic block. Once the prostatic block is done, then the discomfort level is not any different compared to transrectal route. The other main disadvantage is in case if we are taking biopsies too many, patients can have a slight increased risk of urinary retention compared to transrectal route. Other than this, the advantage of transperineal approach is we can get good chunks of biopsies all throughout the length of the prostate from apex to base. So if you see here, for example, in this prostate specimen, if you are able to follow my laser pointer, the transperineal prostate biopsy needles will go from apex to base. So you will be getting full core thickness, long, nice cores. While transrectal means the core will be traveling only the prostate from the sideways. So obviously the amount of length of the core will be slightly less in transrectal route compared to transperineal route. And in transrectal, sometimes it's quite difficult to biopsy the apical area, while in transperineal route, we can biopsy the apical area quite comfortably. Today, in my presentation, I'm going to discuss what is the importance of doing MRI scan before every prostate biopsy, why transperineal route, what is fully freehand technique, which is what we are doing in our unit, what are the guidelines, what is the practical tip, what is the training involved, and what is the future in these biopsy techniques. There is no doubt that MRI should be done before any prostate biopsy. What is the evidence? Even before going to the evidence, it's become more like a common sense. If you are traveling from city A to city B, what you will do? At least you will open a Google map, at least you will open a paper map if you have. You will know about the routes to take. So it's as simple as that. How can we do a prostate biopsy without even knowing what is happening in the prostate and where we are heading to take the biopsy? MRI biopsy gives us a good idea about what is happening in the prostate. There are good quantifying tools like Pirate score system, which further tell us where to target and what are all the significant and less significant areas. Say for example, the publications as back as 2018 in New England Journal of Medicine has clearly shown the significance of patients who are having MRI target biopsy. They get better identification of clinically significant cancer, less identification of clinically insignificant cancer, core positive for cancer is better, and MRI is really useful in identifying the lesions. In the non-inferiority study, the MRI with or without target biopsy scored well above the non-inferiority margin. In fact, it's above the zero itself. And when we biopsy the PIRAD score lesions, as we know, PIRAD 3, 4, 5. 5 means there is a definite evidence of possible cancer. 4 is a high evidence of cancer. 3 is equivocal, but if the prostate density is more than 0.12 or 0.15, it's better to biopsy the PIRAD 3. While PIRAD 2 should not be biopsied, it's benign. PIRAD 1 is not reported. We can see that as the PIRAD score is increasing, the clinically significant cancer, which is in orange, is getting more diagnosis. So in conclusion, patients with clinical suspicion of prostate cancer, risk assessment with MRI will improve the diagnostic pathway and improve the clinically significant cancer finding. There are some other publications also in European urology which had head-to-head comparison of transrectal ultrasound biopsy with MRI or without MRI, and it clearly proved that MRI improved the diagnosis of clinically significant prostate cancer. MRI became quite common in this MRI first trial. Again, it showed that it diagnosed clinically significant cancer and also less chances of finding insignificant cancers like Gleason 6 prostate cancer. There is a Cochrane review which has looked into 18,159 records through the database searching. Again, it found that there is a good evidence to say that MRI should be done before any prostate biopsy. It's as simple as looking into the map before we are traveling. EU guidelines, the latest 2024, has got strong evidence to say that perform MRI before prostate biopsy, at least before the first prostate biopsy. And if it is positive, like equal or more than 3, we need to do combined target and systematic biopsies. As I already said, transperineal prostate biopsy has some advantages, but what are all the evidences published? So this is a paper on global prevalence study on infections in urology, known as GPIU for people who are going for exams. This looks into the global prevalence of infection in urology in various aspects, right from kidney to prostate, everywhere. There is a good amount of evidence to show that patients develop lower urinary tract infections, positive urine culture, need for treatment in primary care, need for hospitalization, or sometimes need to access the emergency care in patients with prostate biopsies done transrectally. The only thing is, already, as I said, the infection pattern in transrectal prostate biopsy is not bad. It's only 0.2% in our own institute, which is like 2 out of 1,000 people. That's why it's very difficult to prove statistically that transperineal will cause less infection. But we have an ongoing audit going in our department. We have reached almost 1,000 transperineal biopsies in our unit. We have 3 consultants and 2 nurses performing the biopsy. The reason I'm saying this is even your unit's nurses can be appropriately trained so that protocolized procedures like flexible cystoscopy, transperineal biopsies, transrectal volume measurement of the prostate, and protocolized clinics like stone clinics, increased PSA clinic, lower urinary tract symptoms clinic, they can be handled easily by the trained nurses, freeing the doctors to do maybe more complex things like maybe attending the theater, etc. And this study, global prevalence study in infections, clearly proved that there is an evidence of increased lower urinary tract infection with transrectal prostate biopsies. In transperineal prostate biopsy is proven by the PREVENT randomized trial. The PREVENT aimed to see that are we really preventing the infections, etc. 658 patients were randomized to transrectal fusion biopsy and transperineal fusion biopsy without antibiotics. and there is a good evidence to say that there is no difference in the infection pattern. So if you are doing a procedure without antibiotic, which causes infection pattern almost similar to a procedure with antibiotic, obviously we need to choose the procedure where we don't have to use the antibiotic. That gives us the ability to create that antibiotic stewardship. So the confusion says that if you are doing transperineal without antibiotic, there is no increased risk in any infection. And looking into the complications for transperineal approach, again, this Journal of Urology paper looked into 718 patients where they were randomized between the transrectal fusion and transperineal fusion. This is the protocol for transrectal and transperineal. We will be sharing the recording of the procedures so that the trainees who are interested can go through these kind of tables quite in detail in your own time. And we can see that transperineal is as equivalent to transrectal. So if you're able to achieve the same results without using antibiotic, as I said, especially not using ciprofloxacin is quite good in preventing the antibiotic resistance. You can see in this picture the incidence of fever, incidence of genitourinary infection, incidence of sepsis, and incidence of readmission due to infection. They are all quite similar between both antibiotic and no antibiotic group. And this is a chart which they have published in Journal of Urology comparing the safety of the transrectal and transperineal approach. We can see that the infection rate is quite comparable, so we can do a procedure without using antibiotic. Is there any role for prophylactic antibiotic? By meta-analysis and systematic review, it was looked in the European Urology. It clearly said there is no need for antibiotics if you are doing a transperineal procedure. Hence, in AAU Guidelines 2024, there is a growing body of evidence to show that antibiotic prophylaxis may not be required for transperineal prostate biopsies. What about non-infectious complications? We know that usually we'll explain while doing the consent that possibility of hematuria, hematochezia, hematospermia, pain, and acute retention. Obviously, hematochezia is completely removed in transperineal approach because we are not puncturing the rectum. Hematuria, hematospermia, pain are a part of biopsy procedure like any biopsy head to foot. Apart from that, there is a slight increase in acute retentions in transperineal approach, especially if the biopsy needle is not appropriately targeting the peripheral zone and we have to travel via urethra or bulbospongiosus muscles to reach the transition zone or central zone lesions. Obviously, when the urethra is transferred, the urethra will go for a spasm and that may cause a bit of a discomfort and patients ending up in acute retention after transperineal approach. It is transient. Those who are taking tamsulosin or finasteride or any medications, that's more than enough to relieve the retention. Is the prostate cancer detection rate is better by transperineal route? It was looked in the Journal of Urology paper. There is a clear evidence to say that there is a better cancer grade definition. We are able to find better clinically significant cancers and avoid non-significant cancers. Like Brexit, what happened in United Kingdom where our country got separated from the European Union. Trexit was equally a very famous word in 2020. Trexit stands for transrectal route exit. So we are exiting from the transrectal route and we are heading towards the transperineal route. So there are even publishing papers in the name of Trexit 2020. Now I'll go through some practical tips of how to do this procedure so that if somebody is interested, we can institute and we can do some mentorship. First, we need to know the anatomy compared to transrectal biopsy where the patient will be lying in the left lateral decubitus procedure. In transperineal approach, patient will be in lithotomy, which is a quite common position and urology patients are quite used to that. Since the patient is awake, we will request the patient to hold the scrotum away in a very gentle manner. And it's important to understand the anatomy. So we know the main things are the anal verge and entrance to rectum. and this is where the bulbospongiosis is there, taking the urethra. So the prostate is in the base, in the curve of the bulbar urethra. So the area which is important in giving local anesthesia is this triangle, if you are able to follow my laser pointer. So the triangle is formed by the bulbospongiosus muscle covering the urethra, laterally by the ischio-cavernous muscle, and in the base formed by the transversus perineum superficialis. It's covered by a diaphragm known as fascia diaphragmatica. You can see this even in the cadaver specimens, a very clear evidence of the triangular area. So if you are able to pass the needle in this area to give the block and also using this area to get the biopsies, you will not travel through the plenty of muscles and neurovascular region, and also you will spare the urethra, so the chances of acute retention and the procedure related pain will be much better. So from the lateral cut, this is how we are using the transrectal probe, and in this example there is a guide through which we pass the needle and enter the prostate to take the biopsies. I'll be showing this with the help of a video. Apart from the fully freehand technique, which is what we are using, we are not using any guides to take the biopsy. One of the commonest method famous all over the world is by using the precision point. As you can see, it is a kind of a guide which fits into the scan probe, and by using this guide you can take the biopsies at different regions of the prostate. So this is how the guide will be mounted into the transrectal probe, and there are 5 holes in the guide, and we can use the biopsy needle to get into to take biopsies from left side and right side. So the left and right are done by 2 separate point of entry. So we use a guide needle so that the guide needle will go once and we don't have to go repeatedly in one side. If somebody has got very small prostate like 20-25 cc, we can even use a midline single puncture through which we can enter and reach all the prostate gland. But in general, we come across men at least with 35 or 40 cc as baseline, and we have come across patients even with 100 cc or 200 cc in average. So it's always better to have a separate puncture and separate block for the right side and left side, so that the block will be also nicely done and also the samples are taken in a more comfortable manner. If the needle is passing straight from the skin, it will give you a nice lengthy core, thick core, while if the needle is traveling in an angle, it won't sample the prostate appropriately completely. And we have our own NICE guidelines published last year 2023 recommending the local anesthesia transperineal prostate biopsy using this freehand position is the procedure of choice. But what kind of guide can be used, whether we need to use precision point or other guide, like for example there is a Trinity Pyrenees guide, there is a Cambridge guide, there are so many guides available, or by using completely freehand like the technique which I'm going to show, there is a debate still going on which is the best way to choose. The advantage of completely fully freehand method is we are not bound by any of the guides. So the operator has the independence to take the needle into the areas where they need to take the biopsy. And it sometimes is quite comfortable and it's also economical, since we have to save some money by using the guide, because the precision point guide is quite costly. It's cost almost equivalent to 240 pounds per patient, and it's a disposable one. So we will be using it every patient 240 pounds, which when translated to the Asian country currencies will be a very cost expensive option. Now I will show you a video explaining how this fully freehand technique without guide is done. So as you see in the video, you will be having a needle and a coaxial one. The biopsy can be done in an office. There is no need for any special theater or anything. As I discussed, there is a good decrease in the infection, decrease in the sepsis, and ultimately the death can be also prevented. And the advantages is this transperineal approach is fully supported by the European guidelines, NICE guidelines, AUA guidelines, and if you take any country, the guidelines are quite supportive. We need to know the equipments what we are using. The transrectal probe which is used is almost similar to the previous probes. I will pause here to show that we need to have two sets of anesthetics. One anesthetic is for the skin, the other one is for the deep one. And this is the needle guide. We need a marker pen for the initial stages at least to mark where we are getting to. And this is the BD mark needle which we use regularly. Sterile drapes, some swabs and dressings if needed. Mostly the patients may not need any dressings nowadays. We can send the biopsies at least in two pots. We are all quite familiar with the endoscopic probe. The probe used for transperineal is slightly different. So we are using this 18 gauge needle with a coaxial one. The advantage of coaxial needle is, as I said, once you place it in the right side, we can go multiple times without entering the skin repeatedly. It's quite comfortable for the patient. The coaxial needle comes with the BD marquee kit and it plays as a very good partners. Patient will be kept in a low lithotomy position and we are doing it in our office setting. The patient's perineum will be prepared. This is the rectum and this is the place where we are heading to. And usual preparation, the best one is the povidone iodine, or if you have any chlorhexidine spray preparation, which is equally good. Once the preparation is done, we know that just leave it like another few minutes or few seconds depending upon your practice. The probe will go into the anus and we know we need to reach the prostate. The local anesthesia commonly used by me is 2% lignocaine, which is more than enough. We don't need bupivacaine. The procedure as such takes only maybe like 15 to 20 minutes. From the anal verge, we need to mark 2 points on the left and right, which were 1.5 centimeters from the anal verge. In the initial stages, of course, a surgeon will be interested to mark it by using a marker pen, but as you gain experience, you don't have to really mark it meticulously. 1% or 2% lignocaine are equally good. 2% will give better, longer anesthesia. You don't have to top it later. We can use a cool numbing spray. We use a chlorhexidine spray, which is also slightly colder. The colder spray itself will block the area. Here you can see 2.5 milliliters of the 1% lignocaine is used to block the skin and subcutaneous alone. Once the skin and subcutaneous area is blocked, we can use the guide coaxial needle. The guide needle will be taken inside and nicely placed so that we can use the guide needle to give much more deeper anesthesia so that the prostate is nicely blocked. So with the transrectal probe in place, the guide needle is taken up to the periprostatic tissue. Patient will be kept under, I will say, like vocal anesthesia, which means somebody needs to talk to the patient and keep him engaged. Most of the patients in our units are big football fans. So if you know which football team they support, that makes the whole procedure little bit comfortable. So you need to change your interested football club for every patient and support the patient and be with the patient as a team player. And once we pass through the pelvic diaphragm, that's where the patient will feel the pinch. But once the pelvic diaphragm is penetrated and prostate is blocked, the whole procedure should be painless. And then we know how the biopsy needle works. This is the same biopsy needle as what we use for the transrectal approach. In BD, marquee kit has the advantage to have like a half engage and full engage during the procedure. And we can use the biopsy needle to take biopsies depending upon the areas which were identified by the MRI. And we have a good protocol of selecting 1, 2, 3, 4 on the right side and 6, 7, 8, 9 on the left side. There are some units send multiple pots. In our unit, we send one pot for the right and one pot for the left for the initial biopsies. But when patient has repeated negative biopsies, but the PSA is creeping up, we may have to do more saturation biopsies and more pots to make sure we are getting the biopsies fully. The BD marquee needle has got the advantage of getting good thick cores. It's always better to transport these cores into a kind of a foam which can be put into the formalin. And nowadays our pathologists are quite confident and they are used to the better cores by this transperineal route. The advantage of BD marquee kit is again is like the needle is completely marked, so you know what is the depth you are traveling, and it is very radiolucent with the transrectal probe. You will be able to reach anywhere, right from anterolateral, posterolateral. You can reach any part of the prostate. While in transrectal route, as I said, sometimes reaching the apex is quite difficult, but here we can reach any part of the prostate. In very large prostates, sometimes reaching under the pubic arch may be a challenge. But since we have this fully freehand technique, we have the ability to angle it appropriately and reach the behind the pubic arch prostate also. If you use any guide, the guide will restrict you from reaching them. This animation is showing a dressing, but normally there is no need for any dressing for these procedures. Appropriately labeled pathology request is useful. Coming back to the presentation, the take-home message for today's presentation is patient's first biopsy should be done with MRI, never do without MRI. Transrectal biopsy has a possibility of mortality, even though rare, it's equivalent to almost radical prostatectomy itself. In the era of multi-resistant superbugs, we must stop cultivating them. As a principle of antibiotic stewardship, transperineal biopsy will help you to do the procedures without any antibiotics. Transperineal biopsy is safe, it has excellent detection rate, it has biopsy without antibiotic possible, and it is recommended by the guidelines all over the world. Thank you very much. At one point, when things were stable, we should be able to do a transperineal biopsy workshop in the National Pakistan Association of Urological Surgeons annual meeting. This is our brand new shining hospital, which is going to be opened in the next few weeks. Mr. Sami, as a leader, has got a good time involvement in setting up this unit. We have only something like 5 minutes left in the Zoom. So by chance, if the Zoom throws us out, we can join back again using the same link possibly. Thank you for the opportunity. Looking forward to conduct a workshop soon. Volume is not enough, Jawad. We can't hear you, Jawad. I think your side mic is off. Oh, sorry. I can hear you now.
So, are you doing a transrectal biopsy at your center or not?
We have completely stopped the transrectal biopsies and we are fully doing only transperineal. So 3 consultants and 2 advanced nurse practitioners got trained now.
My name is Dr. Francis. My question currently is that there's always especially for our resident or even that.
Sorry, can you speak up a bit? Can't hear you.
You can hear me right now?
Yeah, bring mic a bit closer to you, please.
Very close, sir. Sir, my question is for the diagnosis, there is a query whether it's the biopsy or it's the MRI. When to choose when? Kindly can you ask that question?
Yeah. We haven't reached the stage where we can entirely depend upon MRI alone and say that there is a definite prostate cancer, so we can take the patient for radical prostatectomy. So we are in a stage where we will do a biopsy before entering into any treatment protocol, either active surveillance, watchful waiting, surgery, or radiotherapy. MRI is good, but not good enough to say that, okay, this MRI shows a definite PIRAD 5, definite prostate cancer. We don't need a tissue sample and we can go ahead with the treatment. So, as of now, a definite MRI followed by prostate biopsy. Based upon the biopsy protocols, based upon the PSA values, patient also needs further staging like CT scans and bone scans. As you said, a day may come where the MRI is so good where we don't have to even take the biopsy. Like, for example, kidney cancer. We don't have to do biopsy for every patient. If the lesion is quite significant, we are going ahead with nephrectomy or nephrouretrectomy based on TCC or RCC. So the day may come, but not yet. We need both.
Even for there are five biopsies still needed for the treatment, for the development of form of documentation in the same lab.
Yes, we definitely need biopsy before giving any treatment. Yeah.
Can I just elaborate
Yes,
on?
yes, Dr. Tariq Sami, I just want to have your opinion as well.
Okay, so excellent presentation as always, Ananda. Great to
Thanks,
see
Tariq.
all the evidence and the technique very well described. I'm just participating in this MRI before the biopsy. First of all, MRI scan has been used for many, many years, and initially endocavitary MRI and internal coils have been used, which people thought increased the yield, but at the same time they were difficult to use on every patient. The minimum MRI you need is 1.5 Tesla, and you also need a good kidney function with EGFR of more than 30 minimum to get MRI done. Better to have a 2.5 Tesla machine, or even better if you have a 3 Tesla machine. So these are few of the caveats about MRI. It does increase the yield. It makes the target easy. But if you have on digital rectal examination a very hard prostate in a very old man, where you only need tissue for diagnosis, you don't need MRI scan. Similarly, those patients who are older, above, I would say, 80 years of age, where MRI is not going to be used for planning of your surgery or further management, I'm sure Ananda will agree with me that you don't always need an MRI scan. So those are a few caveats about MRI scan. Be very, very sure and cautious about asking for MRI scan in those individuals who have impaired renal function, particularly who have a past history of nephritis and things like that, which are very, very common in Pakistan. So because the contrast use can really affect the kidneys, and you can easily shift a patient into renal failure if not careful. So in Pakistan,